morning, everyone. How are you?
Good morning.
Good morning.
Still technically morning, right? I know it's 11:58, so we've still got the morning here where I am.
It's 8:58 here where I am.
So we clearly have morning. We're good. We're good to say good morning then. That's no problem.
We've got people from all over. Well, I'm sure in our audience we have people from all over, but we've got Dr. Makka from New York, or Long Island, New York. We've got Kathleen in the beautiful sunny Arizona. Lovely.
Lovely. And I hear we're having nice freezing rain back home in Ontario and cold weather. So I was very happy to be here.
I woke up to snow this morning. There was like a centimeter of snow on my deck. I'm like, no, yesterday was 16 degrees and today it's snowy. I don't quite understand it, but that's okay.
Yeah, I know. My son came over in shorts yesterday. It was beautiful. Yeah, it was beautiful. It was like Carrie said, it was 17 degrees up here. It was gorgeous. We had lunch outside in an igloo. One of the not that it was made of ice, like one of those bubbles. I always call them an igloo. The bubble.
You ate lunch in a bubble. That is awesome. Well, we've got a large group of people that have signed up already for this event. I know we're live on Facebook, so if you're following us from there, we are very excited to have you. I know it's going to be an amazing, amazing session. We're excited to have Joanne back and Dr. Parul to join us, and we'll go from there. So it's going to be a great, great event.
All right. Well, I think we're right at 12 o'clock now. So I just have a little bit of housekeeping to go through, and then I'm going to pass it over. Dr. Parul Makka, we're very honored and privileged to have you here with us today. And I do want to make sure you get the introduction you deserve. So in a moment, we're going to introduce our guests for today. But before we do, just a little bit to go over here. We have a really large group joining us because, well, this is a really important message. And I know that there's been a lot of interest and a lot of excitement to come on and hear the important message today. For that reason, we're going to try our very, very best to address questions that come in. But if we don't, we will have a way for you to contact anybody who can help you out with your question. So if you just have a comment with something that we're saying, please use the chat function that you see on the bottom of your screen. If you have a question that you're looking for an answer for, if you can use that Q&A function, that way we'll have a record of it moving forward. That said, I'm here in the background if anyone has technical questions. Otherwise, I hope that you enjoy today. And I'm going to pass it on to Carrie, if you could introduce Joanne for us, and then so on and so forth.
Okay, Beth, but does Joanne really need an introduction? Just out of curiosity. I feel like Joanne is like a common name. You don't have to say Joanne Jones. We just say Joanne and you're like, oh yeah, Joanne Jones. So I really, I don't think I need to read your bio or anything else that way. We are so pleased to have you back joining us today. And particularly to kick off Oral Health Month and Dental Hygiene Week next week. It really is an important time. And so truth be told, we are so happy that you are here joining us again as you make many guest appearances with RDHU and on The View. So I would like to, with a warm welcome both of you guys to join the show. So Joanne, you may take it away.
Thank you so much, Carrie. I really appreciate it. Before I introduce our lovely guests today as well, that we have the privilege of spending some time with, I really, really want to thank the RDH View for your commitment to elevating awareness. Every year you do something very, very special in recognition of Oral Cancer Awareness Month. And I really, really, truly appreciate that. So without further ado, it is my pleasure to introduce Dr. Parul Makka. And I am so absolutely honored, absolutely proud to have her as a colleague, but very honored to call her a friend at this time in my life. So that is a real treasure and a gift to me over the last several months since connecting with her. Let me tell you a little bit about Dr. Parul Makka. Parul actually graduated from the University of Oklahoma in 2003 and graduated with honors, and then went on to practice in private practice practice in Calgary, Alberta. She then moved to Staten Island and took a general practice residency and opened up a family practice in Staten Island, or in Long Island, New York. So that's what she does. But who she is, as you'll find out, she is a very warm, gracious human being with a very sweet spirit, and is the wife of a lovely man. I've heard him speak about her personally, and it brought tears to my eyes. And the mother of 2 young boys that keep her, as she says, very entertained. So that is who she is, and daughter of her 2 parents. And we are very, very privileged to have Parul with us today. She's actually in the midst of clinical practice, still in her scrubs, which I said, don't apologize for that. It's very authentic. So we've only got her for a period of time. So I'm going to shut it down right away and pass it over to Parul with a first question for you, Parul, to kind of start off this interview. And that is, tell us a little bit about, before we get into the story of your younger brother, and the tragic loss of losing your only brother. Can you tell us a little bit about growing up with Manu and entering into the same profession as well? I know our viewers would love to hear about that.
Thank you. First, this is truly an honor to share the screen with you, Joanne, and for the RDH view with your incredible team. Amazing work. So first of all, I wanted to thank for that. And Manu and I are almost 8 years apart. We're 8 years apart, and he kind of followed my footsteps. I graduated dental school in Oklahoma and moved back to Calgary, and he watched me practice and followed my footsteps. He graduated high school at that time, and he pursued my profession, and that kind of joined us because we grew up in different parts of the world, just the way our lives led us to be. And we didn't have a lot of common friends because we were almost a decade apart and 2 different genders. So what united us was dentistry. We took courses together. We would analyze cases, how to run practice. And, he would find something new. He would tell me about it. Dentistry was so much that for my 40th birthday, he got me curing lights as a birthday present. That's how geeky and dentistry united us. Yes, everything was about, that's what our common thread was. And I miss that. Sometimes he would always share, like, he loved endo, and he would share me cases. And now I don't have that person to share stuff with,
So I understand that your late brother had a lesion on his tongue, and he had it there for quite a while, and it was painful. It didn't sort of heal right away. Why was the biopsy delayed? What happened?
So let me show you the lesion real quick, and let's see if I can do this right. All right, so can we see that okay?
Yeah.
All right. So that's him. I think this is him in early part of college. So this was the lesion that Manu showed me, and this is actually through WhatsApp because he was in Calgary practicing. He had just started a startup in 2016, and this was 2019 when he showed me. And I was in New York, so I physically did not see it. But he showed me, and he's like, hey, this has been on my tongue for some months now. I've been feeling a little down. I have pain on eating, uncomfortable, present for months. And I look at it, I show it to my surgeons, that my friends and colleagues, and they said, this is hands down cancer. And it was an ulcerated, ill-defined. He was at that time 32. And the reason why it wasn't pushed for a biopsy was because he was not on the traditional risk factors, where he was not a smoker, social drinker, no other risk. Family history of cancer was just pancreatic cancer, but no other form of oral cancer. And no prior surgeries. He was healthy, no comorbidities. This just wasn't on the radar. And His oral surgeon thought it was lichen planus, and he was on prednisone for about a month, and it did not heal. I flew down in July for the Calgary Stampede. And when I asked him to show me the tongue, it was much progressed. It was brown, leathery, and things just kind of took for the worse. And we had lymph node involvement at that time. But the reason why it wasn't was you just didn't fit the traditional older male criteria. And the other differential diagnosis was irritation from wisdom teeth, which he subsequently had them removed, but no biopsy done even at the time of the extraction of the wisdom teeth. So I think it was just an oversight, and we feel that cancer can't affect us, especially not one of us. We are the ones to diagnose, right, as dental professionals. And we just don't think it can affect us. So it got missed.
So do you think this is HPV and, this caused the cancer, or are there any tests that could have been done ahead of time to get, more towards some type of earlier diagnosis?
Earlier diagnosis would have been the key, seeing the lesion, any unhealing, long-standing lesion, painful or not. Manu's was painful, and he kept telling me, this is painful, cancer isn't painful. I think it's lichen planus, which is painful. So I agree with my surgeon. But any lesion at that point should be biopsied in general. But is this HPV related? No. It wasn't tested. We didn't do any gene testing. At that point, it was important to get him care and the surgery. And and also HPV is more related towards the oropharyngeal, like towards the retro area, more of the throat. So this was on the lateral border of the tongue. So no, I don't think it was HPV related. And as far as testing for HPV, it's really hard. Yes, we have it for women. We're doing pap smears, but for men, there are no HPV tests. HPV is a virus, so it can stay dormant in your body for decades even before you see any symptoms, or our bodies just, take care of it. Like our immune system can take care of the virus, and we don't show any signs, or it's not active in our bodies. So it's a very hard test to do. There's no salivary tests. And by the time you actually even test it, you may not have it anymore. So it's a very tough field right now. So the only way would be to see a lesion and push for the biopsy if it's not healing. So.
Wow.
Dr. Parul, you've given us a little bit of insight as far as kind of when your brother started noticing the lesion, but as far as when the actual diagnosis was given, how quickly progressing was this lesion? Like coming from the actual diagnosis to his passing, how rapidly did that take place?
Very rapidly. It's a very aggressive, even especially in the young. So Manu was diagnosed in August of 2019. He had just turned 33, and he had a major surgery where half his tongue was resected and a graft was placed. And it was an 8-hour surgery. He had an incredible team with vascular surgeons, oral surgeons, pathologists, plastic surgeons, ENTs. He had a trach placed in. I mean, this was an extensive 8-hour surgery with a 2-week hospital stay. He also had lymph node involvement in his neck, so those were removed. However, he did not have any chemoradiation offered to him, and it wasn't pushed for, which I felt was a bit of an oversight from the surgeons, because this was a healthy 30-some-year-old male who would have handled the post-op effects. And I would say within 8 months, so April, just when COVID was starting to hit US and Canada, the borders were getting shut. Manu had some dental procedure done, just something very minor, and he had a swelling, and the swelling was on his neck where the lymph nodes were removed from. The swelling was positive for squamous cell carcinoma. And at that time, they even saw a lesion on his chest, a ground glass opaque lesion, which wasn't pursued for, it was too small for a biopsy, but no PET scan was done. And it was suggested that all the lymph nodes weren't removed and from the initial surgery on his neck, and thus the cancer returned. And so hindsight's always 2020. I hope that, you know, changes are made to the protocols that following a major surgery have the chemoradiation, so that whatever remaining cancer cells are left, they are taken care of, so that no person has to suffer remission, you know, come out of remission and go through another round of surgery, which Manu did. So in April, he had another surgery to remove the neck lesion. Now he got chemoradiation, and still no PET scan was done. Chemoradiation was in the summer of 2020 during his 34th birthday. And so you can imagine COVID, no emotional support, not a lot of visitors allowed, completely shut off because he was immunocompromised. I'm not allowed to travel. Canada borders are shut. It was a very tough time as a family trying to navigate through that. And we're not vaccinated because vaccines weren't available at that time for COVID. And in November, so this is all, you know, very quickly. And just as a reminder, Manu was healthy rugby. He played rugby for his high school. He played badminton. He played golf. So he was physically and mentally very alert. That when he did his initial surgery in August, he was back to work seeing patients in October. He even traveled to New York to see me in September. So he could have handled a little, but he was mentally very strong and he fought through everything. In December of 2020, he had a follow-up scan in November, which showed that the chest lesion had grown 4 times the size, and he was scheduled for a biopsy. Before the biopsy happened, he ended up in the emergency room with fluid in his lungs. The biopsy was never done because they took the fluid sample and that was positive for squamous cell carcinoma as well. Now the PET scan was done and it was deemed inoperable, that in his lung lining, and there was no hope. At this point, the time was limited. It was just spreading rapidly. And the PET scan also showed metastasis to his pelvic bone on the left side. So it was just a matter of months at this point. And that's when I had to make a decision to go see him. And amid COVID, knowing that I have my own risk factors, shut down a practice, closed down for 2 weeks, 1 week to go, 1 week to quarantine when I got back, get a special permission from the government of Canada to go on a compassion release basis. So I didn't have to quarantine while I'm in Canada and have that fear that I'm traveling to go see him. What if I could transmit COVID to him? So I had to have a mask on 24/7, be on a different floor, just see him, be around him for a little bit, whatever I could do. And so it rapidly, from then on, it was just a matter of time. It was many multiple visits, cancer. As the cancer grew, he started losing a lot of weight. And eventually, I could not make it in time, but eventually he went into hospice. He had a pulmonary embolism, and I had to say goodbye to him on WhatsApp because I couldn't get in. I had all my paperwork. I couldn't get there because of a PCR test, which is required by Canada at that time. I was vaccinated. I had all my compassion release paperwork, limited release forms that Manu had signed because you're only allowed certain spots. And all I was missing was a COVID, the PCR test. And so I had to say goodbye to him on WhatsApp and tell him, let go, and you're done suffering. You're done. You fought your fight and you can go now. And by the time I booked my flight, I was packing my bags, telling my kids goodbye. He passed that evening. So, and then I flew in the next day. Yeah.
Oh, so sad. Oh my gosh, my heart hurts just hearing your story. So Parul, what is the message that you want to get across to dental professionals? Like, what would you like that to be?
So my whole thing is, we need to be more diligent about our screenings. We really need to be asking questions and listening. Just this morning, I had a patient who said, hey, there's something I feel weird on the palate, and I looked at it. It looked a little, it's unilateral. So you want to look for those unilateral lesions, pain on swallowing, any of those telltale factors of oral cancer. Know that it's not always painful. Sometimes it is painless. It's just an abnormality in cells that we need to be looking for. We need to be knowing their health histories. Are you smoking? And this patient that I referred this very morning, I said, why don't you go? Because he's like, I vape, I have used hookah, and patients need to know that hookah is not safer. Vaping is not much safer than smoking. It is worse, if not anything. So be aware of the risk factors, and be diligent with dentists. Be diligent in our screenings. You notice something, let the patient know, hey, I'm going to just watch out for this for the next couple of weeks. Send in for the biopsy. What's the cost of not doing a biopsy in time? Even if you think that is something totally like lichen planus or something totally benign, what's the harm? You'd rather know early than not know at all and it's too late. So pushing for those earlier biopsies, send it to a pathologist, send it to a surgeon, send it to another set of eyes that can take a look at it and confirm or deny, because you'd rather be safe than sorry. So that's my biggest message to all dental professionals. It's look, see, watch it, refer it. Don't keep watching it for years or months. It's 2 weeks. That's it.
I think your message really resonates with so much of us, so many of us. And I do find sometimes you see these concerns and you're like, I don't want to alert them and I don't want to make a big deal about nothing. But I think the truth is we really need to give them the option. We have to educate them. We have to tell them we can't just keep this information to ourselves. And, I think that is so important. And a very good point is, the younger generation, we don't think they're going to have a heart attack. We don't think they're going to have a stroke, and we don't think they're going to have oral cancer, and they can. So if we see something, just because they don't fit the typical bill, they can be healthy, they can have all those things, we still need to be very diligent and go that extra mile and just try to push and advocate. And that's where you were trying to advocate for your brother the best you could. And it's like, okay, wait a minute, looking back at the past, maybe there were different avenues, hindsight's always 20/20, but being that advocate, being that quarterback for our patients and just giving them the information, the plays and the calls. So I really am so touched by your story. And the movement that you and Joanne, and I call it a movement because you guys are doing so much for the profession to move us and make us want to change. So I just want to say thank you. Sorry to interject.
No. Joanne's been great in helping me get this message across. She's been an angel, and I say that universe connects you in so many ways to different people that, I just didn't want Manu's life or his death to be just another statistic. Here's another 30-some Canadian who died of oral cancer, but this for a wake-up call for us to push for those and look out for these signs and know, especially for dentists too, know that there's a person attached to that tooth. So don't just concentrate on that filling. There's a whole person, we're the gateway keepers of oral health. Everything dictates how you feel is how you eat, and how you eat is how you take care of your teeth and your oral health, right? Your checkups and cleanings and getting your good perio. I mean, it's all related to so many different, right? For pregnant women, for heart conditions. I mean, the list goes on, for high blood pressure, for diabetes. It's not just cancer. So we are very, our care is very important, and we need to advocate for that ourselves, to work in unison with, and I'm gonna.
This is real, people.
Sorry, that worked.
This is real life.
Yeah.
I love it.
We need to work together as a team and realize that the overall care of the patient being the ultimate goal. So that's really, really key.
Great comment, Carrie. And Parul, your story, Manu's life will never be in vain. The shock waves that have gone through our community have just been incomparable. Nothing else can compare, really, because of the feeling of being invincible, as we talked about earlier, because we're in the profession. Like, this is just the height of awareness. And I think I'm getting way too old at this point to sugarcoat a message anymore. I've got really, really strong about this message, because people, we need to up our game. We need to do better. And I'm finding lately, and again, maybe it's related to the chronological enrichment piece of my life and the aging aspect, but I find the emotion is taking over. And hopefully there, with your message today, and I'm sure there will be, an emotional transfer of knowledge that people don't forget. And one thing I know you've got to get back, because you've got a patient sitting in the chair, bless your heart for even taking the time out. But I want to talk about this book, and I'm going to talk about it later on, because I'm going to do a little bit of a presentation as well for clinical practice following this interview. But Manu's book, I read it and I reread it, and it's highlighted in here on several pages. The clarity and the insight he had is just phenomenal for a human being of that age. Like, there's just so much power in this book. And I just want to know, like, why the title Life Interrupted, and tell us a little bit about how the book evolved, because I think it's so fascinating how it all came together.
So like I said, I reached his house a day after his death, and I checked his mail, and there was the article that he had written for Dental Town. That's where he wrote a lot of his articles. And the first article he had, or when he was featured on the cover in 2019, he talked about his oral cancer diagnosis, his surgery. So it was his journey that he initiated and shared with the world. I'm just helping complete his message. And after his death, the Mail showed the second article in the Dental Town, which was about leaving dentistry this way out, how he had decided to quit practicing because of cancer, and he wanted to concentrate more on his health and focus on getting better. And that kind of created a whole, like Joanne said, it spread like wildfire. It created this sense of awareness of who he was, his writings. And he had been blogging his journey, because during COVID, it was very hard to get any sort of release. He couldn't go out. It was cold during the last months, December on, when he had got the chest port in. So he was very cold. He wouldn't step out. He couldn't walk. He couldn't see a lot of his friends because of COVID restrictions. I couldn't be there. A lot of family support wasn't there because we couldn't travel. So he found his solace, or his outlet, in writing, and this is a way to express himself. One of the articles that he wrote, the last article he wrote, was about moving on, and it was when he was in his last stay at the hospital for 2 weeks. So everything that he would write and he would share with me. And after his death, I found all those articles, and he had expressed a desire to be published, but he kept telling me not to be pushy. Big sister, he's like, I got time. I want to write more. I do want to be published. And I had a publisher in mind. We had, our preliminary talks. So when he passed, I wanted the one thing that I couldn't do. I couldn't do a lot of things, but at least, fulfill his wish. We got all the paperwork together, and I started writing, because I wanted to know, or I wanted the people to know, that there was more to him than the disease that took him, that he was a young, vibrant man. He had a full life, and he had so much to offer to the world, and what was taken away. So that's where the epilogue comes in, and the foreword is just, my little blurb about who, what it was that we're grieving. And so that's what we did. I got on his laptop in his house and wrote his words and got it all together and out for the world to see, because like Jan said, he had life lessons in there. This was somebody who played both sides of the coin. He was a doctor who diagnosed other patients with oral cancer, and he suffered the same. And he talks about mind-body experience, about leaving his body, so to speak, so that his body can go through the treatment, because he was in so much pain, he almost had to dissociate the pain and the feeling. And he talks very frankly about the lessons that he learned in his short life. And I think it's very astounding to read, because he was so young for him to write these words. This is when we're finding our footing. He's 30 some years, we're just getting to know ourselves at this point, and he knew the nuances of life. So he had reached a state of nirvana, if you will, separating mind and body. Yeah.
I'm going to share some information at the end of my slideshow presentation about how you can actually obtain the book. I think it should be valued at 3 to 4 times what it is valued at. That's just my little 2 cents worth there, because it is, for me, it was life-changing.
Yeah.
There's so much in it that's so rich. So thank you so much, Parul. I know from all of us and everybody out there that's watching and in the future will be watching, thank you so much for touching our lives.
Oh, thank you so much.
Thank you.
All.
Can I just ask you?
Thank you.
Can I just ask you one question? So
Sure.
a few of the chats I've been watching have come in. Can you quickly just summarize, if hygienists are finding these lesions and they're coming across a doctor that is saying, you can't use the C word, or I don't feel comfortable with you discussing it, do you have any tidbits or words of advice that they can offer or direct their doctors to try to help them on this journey?
Sure. I mean, my patient in the morning is like, do you think I have oral cancer? And I'm like, no, it could be totally benign, because remember, HPV does not just cause cancer, right? Like, oral lesions are not always cancerous. They're sometimes benign. They're sometimes papillomas that are totally, you excise and you're done. So I think let's monitor the lesion for 2 weeks. Let's see if it's progressively getting worse. Do you notice any signs or changes? Like, now it's getting painful, or you're having a hard time swallowing, or you're not able to do certain conditions, then let's get a biopsy. Let's just check it out what it is, and just not necessarily use the C word, because it's like a big taboo. Nobody wants to talk about it, right? But at least be like, let's just get it checked out and see what it is, so we can get the appropriate care. It could be totally something benign, and and then we just get it out and take care, and you go on with your lives. Or if you need further care, we'll get to it depending on the diagnosis. So it's just making sure that the patient feels that we're not pushing them, scaring them. It's more about their oral. We're talking about their well-being. It's like, you don't watch a cavity, right? You don't want it to end up in a root canal. You don't watch perio disease. You don't want them to be, we're taking preventative measures. So kind of the same thing. Let's just get it checked out.
I love that last summary, honestly. I think that
Yes,
really
that was
resonates, and that is a perfect way of just so eloquently put. So I really, on behalf of the RDH, want to say thank you so much for fitting us into the middle of your clinical day. We are beyond thankful, and I look forward to reading. I'm going to order your book actually after the show, so I'm excited to read it, share it, and I really, really appreciate that. So sorry, Joe, I totally had to ask her that question. I just wanted to hear it from her perspective and go from there.
Right. Thank you so
Thanks,
much.
Carrie.
Thank you, everyone.
Thank you for being with us.
Bye-bye.
Thanks, Parul.
Bye, Parul.
Bye.
Okay.
So, yep.
Okay, so I'll share my screen now. Just bring that up. There we go. 2 seconds here. There we go. Everybody seeing that?
Yep.
Yes, it looks great, Jill.
So I just wanted to go over a few things with everybody after having such a powerful interview. And there's a lot that we can take back to clinical practice. And I'm just going to stop share because for some reason, I am not being able to advance that. I love when technology kind of gives us a little bit of a challenge and people get to see what you're like under pressure. Okay. I know you're seeing everything there. So let's try and see if we can get that advancing.
We should have a Reels video of the RDH view, all the little bloopers that have
Yes.
happened. It's like, okay, you got
We
to do
have
this.
many.
Well, count me in, 'cause I think I'm going to be in a starring role. Okay, so lessons learned. What are the learning outcomes today? So I did want to put something together because I know you're getting an hour of CE graciously provided by the RDH view. So there are a few things that are definitely a takeaway. First of all, recognizing the etiologic pathways that are related to both oral and oropharyngeal cancer, as Parul alluded to. And then taking it that one step further, how does this actually change the way, or where are the areas that I really want to focus on in clinical practice as a result of hearing this story and, of course, many, many others? How do we manage an abnormal finding? And how do we elevate awareness? It's April 1st, and that's why when I talked to the cast with the RDH view, we said, let's get this up as soon as we can in April so that our colleagues can have a chance to be able to implement an oral cancer screening campaign or, some kind of awareness within your practice. So there's a lot of resources that we're going to give you that are downloadable free of charge that you'll be able to get. So a caveat to that, everything that you're seeing on my screen is included in a handout that will be provided to you a day or two after, or I'm not sure how quickly, after this is actually televised. And there's also the resource listing with it. So a couple of things to keep in mind here. Something that has changed with the Canadian cancer statistics is that they have included a new grouping or grouped together, including the oral cavity, the pharynx, and laryngeal cancers, as well as nasal cavity cancer. So that's all being put into one group because a lot of it has this common etiologic pathway, which is the fastest growing segment, and that's related to the human papillomavirus. So at this point in time, we look at males, you can see head and neck cancer, 1, 2, 3, 4, 5, number 6 position here. For females, a little bit lower, but still above when you look at the cancers that are listed below. If I kind of tricked you and asked you that question ahead of time before showing you this screen, I think many of us would have probably said, no, you know what? I would have put that a little bit lower underneath some of these other cancers. So etiologic pathways, what's important for us to know that HPV-related oropharyngeal cancer is actually the leading anatomical site for HPV-related cancer out of any site in the body. And this happened in 2012, statistically, where it surpassed the number of cervical cancers. Over the same period of time, this is interesting, the rates of HPV positive rose over 225%, while the traditional etiologic pathways, so our smoking, alcohol-related, more oral cavity, declined by 50%. So a big, big change there. And what Parul was alluding to too with the etiologic pathway for her brother, it's actually less than 3% of oral cavity cancers are related to HPV. So it's a very low percentage. The CDC estimates that 70% though of oropharyngeal cancers are associated with HPV. Other sources say as high as 90%. But something for us to keep in mind when we're looking in that oral cavity, and what does HPV look like? Think of I always say like a little cauliflower. An oral HPV infection is related to approximately 25 to 35% of oropharyngeal cancer. So there is that connection. And that's something clinically important that really resonates with us as dental hygienists. And the other part of it too, the fastest growing segment of oral and oropharyngeal cancer populations are otherwise healthy, non-smoking individuals in that younger age group. So, there's no other way to say it. This is a ticking time bomb that we have to be aware of, and we can no longer have those dental blinders on where we think that the older gentleman, the heavy smoker, heavy drinker is the only one. Parul's story, let it resonate deep within your soul and take it back to practice. That's what that story is about, to be able to recognize that we can no longer discern who's at risk. So how does this come down to clinical practice? When we look at this particular image, and this is one of the only images that will not be included in your handout because of copyright protection. So if you want to take a screenshot, as long as you don't distribute it, please feel free to do so. This is from the CDC, and it outlines in that marked off dotted line the areas where HPV-associated cancer or the virus itself affects the oral pharynx area. So we're looking at nasopharynx, the uvula, the palatine tonsils, the base of the tongue, the posterior wall, all of those areas that are so hard to see. This image will be included. I've had permission to share this, and I've highlighted in your handout as well the areas of the posterior triangle that are so important. And what the clinical significance here is that a neck mass is usually the first possible identifier of an HPV-associated cancer. By then there is lymph node involvement. So yes, you guessed it. By then we're getting into those later stages. So this is a particularly tricky cancer, but our palpation, not just looking for symmetry or asymmetry, but palpating, feeling all of these areas is so important. So along the cervical chain, having, and putting force in that area too, having the client turn their head away so that you can really palpate deeply. In the supraclavicular area, shoulders up and leaning forward. These are critical areas. And many, many people that have had HPV-related oropharyngeal cancer, this was one of the first signs, was this neck mass. So it's so important for us to palpate fully all along the submandibular chain, all along the cervical chain, in this posterior triangle, down into the supraclavicular. And what about inside? Intraoral, high-risk areas are the tongue, the floor of the mouth, the palate, and the oral pharynx area. The tongue, I can't stress clearly enough, don't just look. We have to feel compression of the whole tongue all the way down that full area. When we're looking at the lateral borders, a couple of things to remember. Get that index finger in there and palpate all along the full length of that border. And the other thing is to roll that tongue slightly, because when you're looking at the top, the dorsum, and then you're looking at the ventral surface, sometimes you can miss those areas, and this is a high risk area. So we want to make sure we roll it slightly when we've got it in that little hammock. The floor of the mouth, bimanual palpation. So important to have bimanual palpation, because if we just look, we're going to miss areas of induration that have occurred there that we wouldn't be able to normally see. So that is very, very important as well. And then, of course, looking at the palatal area and the oral pharyngeal by having good visual acuity. And we're going to talk about some best practices here in a moment. The other thing I wanted to direct you to, because this isn't a full day course, I would love to have a full day with you, and it is coming, something that is very special and unique to RDHU. And because of COVID, we haven't been able to offer it at this point in time, but we will have a full day course with all the bells and whistles for best practices. But if you go to dentalhygienecanada.ca/oral cancer, or you can go to the YouTube link, it's all in your handout for you. I do have a video there. It is 8 minutes in length, but that's related to the fact that it was an educational teaching video. You really do not have to spend more than 3 to 4 minutes once a year to possibly save someone's life. So what are best practices for earliest discovery? And I did see some questions that came up. I could see them coming up in the chat box. And I think we're going to have a lovely amount of time, a few minutes at the end, to be able to answer some questions. And I'm also going to give you some information so that you can contact Parul as well, because she's back working in clinical practice. So if there's something that I'm not able to answer on her behalf, you will have her contact information. So best practices are to be educated, be informed. And I'm preaching to the total choir right now because you're all here with us, recognizing those etiologic pathways related to both oral and oropharyngeal cancer. Magnification, loops are so important. You know, sustaining your practice because of better positioning, better ergonomics, yes, that's a huge part of it. And that's my battle cry as well. But my true passion, and I'll say it like it is, if you're not wearing loops, I guarantee you, you're not going to see everything. You're going to miss something. Missing something, how big a deal is it? It could mean the difference between survival, life and death. It could be the difference between better treatment outcomes. It could be the difference between disfigurement. It could be the difference between quality of life. It could be the difference between quantity of life. So I can't stress that enough. I do have a professional relationship with Oroscoptic. I'm just pleased to know that somebody has been using loops. Illumination. Again, working with Oroscoptic, I work with the Spark, which was the first wireless headlight that became available. It weighs an ounce. It fits on virtually any set of loops. So it's not specific to an Oroscoptic loop. Some of them that are wired are less than half an ounce. So they're not something that's heavy that we're adding to the weight at all. And again, that dedicated light source is so important, especially with an erythroplakic lesion, which has a greater tendency to become cancerous or oncogenic than a leukoplakic or a white lesion. Those changes in tissue color are so subtle. We won't see them unless we've got illumination. So that's all fine and good when we're talking about something that's actually visual. But where do abnormal cells start to multiply and differentiate? Below the surface. Am I an advocate for Velscope? Absolutely. And there are other players out on the market too. There's Identify, Oral ID, they're all adjunctive screening devices. Velscope has the market share. It has the largest amount of clinical research and data specifically related to Velscope, but it is a tool along with the others that has an ability to penetrate to the basement membrane to see what we might not have seen visually. Think about it. What would we have seen possibly on Manu's tongue? You know, nobody can answer that question. I'm certainly not, please hear me loud. I'm certainly not saying that would have saved his life. We don't know. We don't know the evolution of that particular lesion. But why would we not want to have best possible chance to be able to see something in its earliest stage? You know, when we're talking about breast cancer, we're talking about other areas of our body, when we are offered the best possible opportunity to see something in its earliest stage, none of us are ever going to say no. The majority of those cellular changes are happening at that basement membrane, and more than 2/3 of what we're finding right now are in the later stages. People, we need to do better. That's all I can say about that. Most of all, perform a cancer screening on every adult every year. This is a visual here. Please feel free again to take a picture of this if you'd like to take this back to practice. This is where we're seeing most of our oral cancer is being discovered at this later stage. This has got to improve. So best practices for earliest discovery, I've put some pictures up of loops, and that is the Spark headlight, and that is the Velscope bundle, which has an opportunity to, through the marriage of science and technology, it has the iPod Touch, where you can capture images as well and send them off. So our management and referral pathway, step 1, always complete your medical and dental history, which includes objective and a subjective interview. It's really important to hear from your client. Are they having changes in their swallowing pattern? I'm going to direct you to some resources too. Actually, I will right now. It's in your handout and it's on my website. It's called 30 Days, 30 Resources. I did it in 2020 when COVID first began in recognition of Oral Cancer Awareness Month. And there's a medical history there that is a checkbox style that your client can fill out before they come into the treatment room. And it has a lot of questions about these subtle changes that we're going to be looking for. Perform step 2, a visual and tactile extraoral and intraoral exam. Visual touch and feel, touch and feel. Don't forget the feeling part of it. So our visual plus touch and feel. And then use of screening devices if available, and photography. Evaluate and document clinical findings. So I'm going to give you, with that 30 days, 30 resources, is a form to fill out and a glossary of descriptive terminology, because we forget, who remembers what sessile is, pedunculated, all those things we forget because we don't see that every day. And this goes back, can be 30, for me, over 40 years ago that I was in school learning all of this terminology. Determine the risk of the lesion. Is it low risk or is it high risk? And again, all in your handout for you to read as far as that referral pathway. Step 5, if the abnormal finding has resolved, great. If it hasn't, always refer. Persistence is key. Anything beyond 14 days always needs to be evaluated. Client education, appropriate recare interval to reassess. Chairside and self-care protocols if undergoing treatment for a malignant lesion are critical. That's where the team from Oral Science does a lot of great work with Princess Margaret Hospital and cancer centers right across our great nation, BC Cancer Agency as well, and have a protocol in place with their product line to be able to treat proactively, preventively, and post-treatment as well. So our role and responsibility: refer if suspicious, persistent lesion. Always. Remember that complaints of any type of paralysis or numbness or tingling, any type of kind of wonky symptom that has come up, loss of taste, trouble swallowing, excessive clearing of the throat, may not be gastroesophageal reflux disorder. Ask questions, refer as necessary. The Office of the Chief Dental Officer of Canada came out with this statement in 2020. Oral health professionals can play a key role in preventing HPV infection and HPV-related oral pharyngeal cancers by raising awareness, counseling, educating, and talking about the vaccine. We do not have approval yet, or the indication, I should say, for head and neck like they do in the US. But mark my words, it is coming. The indication for the HPV vaccine beyond cervical cancer, anal cancer, penile cancer, vulvar cancer, all the other sites, we will have it. We need to be talking about the vaccine. I wrote an article, and there's a link in your handout. Dental professionals should remember the HPV vaccine too. So critical. And between professional visits, checkyourmouth.org. Refer them there. It's a free site. We teach them how to check their mouth between professional visits. So critical as well. And last but not least, be a super spreader. And I know when we hear that, we think, oh my gosh, we're talking about COVID. Forget COVID. Hopefully we can forget COVID. Be a super spreader. Get the message out. These buttons are available from the Oral Cancer Foundation. The links are in your handout. Everybody in your practice should be wearing them. And not just for April. The end of April doesn't mean the end of oral cancer or oral pharyngeal cancer. No siree. It continues on 365 days a year. If you want more education and a step-by-step learning experience in a virtual format, RDHU has an oral cancer bundle, and I've given you the link in your handout as well for that. So some great resources. This is in your handout too. This is from, sorry, I'm kind of rushing through these, but they're all listed with the links in your handout. I want to give you a chance to be able to get some questions answered. And last but not least, again, the book is like $10. It's crazy. I said to Parul, you need to put the price up. Maybe I shouldn't have said that quite so quickly, but for now you can get it probably at that price. Amazon.ca, BarnesandNoble.com. Available there for you. And last but not least, my lovely colleague, and I've truly been a delight. She's become a gift, as I said, in my life to get to know her. She has a wonderful lecture on oral cancer screening, the new gold standard. And there is her email information. So please take a screenshot, follow her on Instagram, and, you know, anything you can do to reach out to say, thank you so much for sharing your brother's story. You have no idea how healing that is. I lost my cousin to this disease. Similar story, very, very similar. And when somebody reaches out and says how much that story resonated with them or changed their screening practices, you have no idea the gratification. It starts to heal that deep, deep wound that's in the body. It starts to stitch it up little by little by little. So please, please reach out to her. I've put a screening practice evaluation that you can take back to your practice. I'm not going to go through each one specifically with you. This is for you to evaluate your practice. Take it back to your practice. And I'd be so proud to know that you took it back and you discussed it with your DDS, with the rest of your team. And you said, hey, you know, we're doing this, this, and this. We don't have this, you know, let's put some of this up for Oral Cancer Awareness Month. It's a great opportunity. So thank you so much. I just want to say one more thing about the book. Manu's clarity and insight, if I can say this without getting choked up, is an insight that as a reader, we can take into a world that he will never know, but a world that is way, way better for having him in it. So I just want to end with that and stop sharing and shut up.
No,
That was a beautiful way.
That was amazing.
Yeah.
Yes, thank you.
Yeah, and a
Thank
beautiful
you,
way to
Jo.
end that. I love what you just said, Jo, because that's so true. He doesn't realize the impact that his life is continuing to have, and I think the way that you just summarized that was fabulous. Thank you for doing that.
I have found too, and I know I hope soon we are past COVID, but I have found that coming back, having that break from clinic and getting back into it, my patients were actually, my clients were really happy when I performed the oral cancer screening. They're like, what are you doing? And I'm like, well, you know, I've always been doing this. And they're like, oh, well, I'm so glad you did that because I haven't seen you in a while. And I'm glad that you're checking and people are talking about it. It's really getting out there. And I think, again, as people are aware of testing and availability, and that's becoming more mainstream, you know, talking about the potential for a biopsy or talking about those things, people are not as nervous about it. There's always a cost associated with it. There's no question. I'm not going to try to like pretend that elephant's not there, but I think we have a great opportunity now to really fine tune our conversation. I'm going to link it definitely to Perio and Decay and all of those things because it's the same kind of message and patients can understand that. And just keep trying to spread the word. And you've given us so many resources. I use some of your stuff in my lectures actually. So I'm like, yeah, I got that one. Yeah,
that is awesome. Can I add something while I'm thinking about it? And this is a really good takeaway too, because we are sometimes hesitant. I have my own thoughts about saying cancer screening. I believe in it strongly. I don't think we should shy away from it. But let's talk about the word biopsy really, really quickly. When I say biopsy, what do we all think?
Cutting.
Yeah, cancer. And cancer, right? We all think, oh my gosh, they're doing a biopsy because they think I have cancer. What about saying to our patient, we're going to send you for a very small tissue sampling? I love those words because it takes the anxiety out of it. It takes that preconception of, oh, I'm going because they think I have cancer. And just another way of saying it.
Love it.
So
yeah, that's true.
I'm watching all these messages.
Yeah,
I can't help it.
So many.
Thank you for so many lovely comments. And I see so many colleagues out there. And Jennifer Cece, oral cancer survivor, another awesome story. Oh, Canada's winner from 2015, I want to say, Best Reader's Choice Award for her story. Just amazing story. Like, glad she's with us. World's a better place for her too, for having had her.
Absolutely.
And there were a lot of people that were in the chat too that shared their own personal story. They were touched themselves, they were touched by family members, by clients, and they were all incredibly touching. And thank you for sharing those with us. Honestly, they kind of, it's a good why behind our do, that's for sure.
Are there any burning questions that I could stay on here half the day, but I don't worry, I won't. But are there any burning questions?
Joanne, I may bring up just a couple of questions, but for anybody who is having to kind of take off at this point, I want to thank you for being here, first of all. And there's a few questions coming in about the resources and handout that you were discussing. So you will receive a follow-up email with the instructions for how you get that handout and also for your CE. So just give us a couple of business days to get that arranged and out to you. So if you have to get going, it will come to you with the email address you used to register for this event. So many stories coming in of just people who are resonating with the message, and either they had a patient or client who experienced this or a family member. So I think this has really kind of tugged at everyone's heartstrings, and so many people, I just want to be able to give everyone sharing their stories a hug, and I wish we could get through each one and address them all. So Joanne, just thank you so much for being so on top of this message and for helping us all improve the way that we approach our oral cancer screenings. Some questions that I'm seeing repeated would be around the rights that dental hygienists have. So if they believe their patient should be kind of following up on a lesion, but somebody else maybe disagrees with that, a few questions around, can a dental hygienist make that referral themselves, or does that have to go through the dentist? So maybe between us here, we can address that question.
Yes, and please, you know, my expertise is very finite in this one area. So when it comes to regulations and other aspects, if anybody else wants to chime in, I welcome that. But yes, we need to take that responsibility. That is in our wheelhouse to be able to make that referral and to discuss that with our client. And I know it is very, very challenging. I've been in clinical practice for over 3 decades. I'm not now, I still have active registration so I can teach and get my hands back in the oral cavity. But I know it's a challenge, and I know it puts us in sometimes a compromised, difficult position, but it's a life that is depending on it. So don't shy away from it. I mean, minimal scenario, if you see something that you are concerned about, at the very minimum, have them reappointed back in your chair in 2 weeks' time. Just tell the business team you want to see that client back in your chair. Pop them in between clients, whatever you need to do. It's so important. And, you know, I welcome Carrie, Anna Louise, Beth, Kath, anybody else chime in on that question.
Yes,
I think what you...
I like having people come back, because otherwise that thing that I'm concerned about is in my dream cycle and I can't let it go. Yeah. And it keeps appearing, you know, to me, and I'll tell them, like, I really need you to come back, like, you know, in the 2 weeks, at the end of the day or the beginning, whatever works, so that we can both be sure. And please use your cameras. Like, the camera just doesn't lie and speaks volumes to how something is changed, even if you're seeing it's, you know, getting better. But you can now, it's actually the best documentation when you can say, look, this is how it looked 2 weeks ago, and look, we don't see anything here now. And that's wonderful. And now you've captured both ends of that potential problem, and you can, like, totally let it go, right? For both of you, for your client as well as yourself. So I love having, you know, that powerful end picture where we can say that, you know, this is resolved. And if it's not resolved, then definitely you're bumping it up the food chain, as I say it, you know, to move it up to somebody else, for them to have a look at, for sure.
Great comment.
Mm-hmm. Mm-hmm. I think that was the main question coming through, was just that discrepancy between the, maybe, you know, 2 parties involved in discussing these things with the patient. So I like how you've addressed that. And Anna Louise, I love that idea of, you know, intraoral cameras and all the tools that we have to track that. So I think that was probably the main question that I have seen come through. And then otherwise it was the handout question, which we've addressed as well. So
can I just ask one thing? I just saw Jennifer CC pop up with something about a referral in Toronto, and I know she has been so helpful to a number of people in having proper referral strategies to really excellent professionals. So could you read that one?
Absolutely. So this is from Jennifer CC. I want to stress the importance of who you send your patient to for the referral. In Toronto, you can send to Sunnybrook to oral pathologist Hagen Kleib. So I will type that name into the chat so that everybody can see that. So it is
Also, you can take a picture.
H-A-G-E.
Mhm.
You can take a picture as well, but in case,
Oh, it's not host and panelists. So yeah, it's not going to everybody.
yeah. So there we are. That's the name there. And that is at Sunnybrook Hospital in Toronto. And they should, and she just continued on her comment and said, they should be sent to someone who sees cancer along with other lesions regularly. If they are sent to a doctor or specialist who doesn't see cancer regularly, there's a higher risk of it getting missed in her experience. And I think that is so true. So once again, one final time, that is Sunnybrook Hospital in Toronto. And the name there I've typed in is Hagen Kleib. I hope I pronounced that properly.
Thanks, Beth.
We are so fortunate to be working in such a wonderful group of community of hygienists and doctors that are really trying to go there. And the stories that people have shared with us, Jennifer CC, you know, for reaching out there and saying, hey guys, this is who you should reach out to. Don't be afraid if you've got a question, reach out to some of those forum groups. There are so many people, if you're not from Toronto and you're from somewhere else and you're looking for the specialist, put it out there and you're going to get some support and information you need. Honestly, it's, we really are trying to better the profession, help our patients save lives, literally one screening at a time, one day at a time. It makes a big difference, and our patients value and thank us. And so I think we should probably conclude the show now, even though we can go on forever and ever. I would like to leave it on an awesome high note of thank you for your expertise, for your knowledge, for all that you bring to the profession, Joe. We've had such amazing comments as usual. If you know someone that missed this show and you want to share it, definitely share it. You can find it on our Facebook group. You can come to our RDHU website and it will be up there on a few days. So please let your team members, let your doctors know to watch this show. There's so much information that they can get from it. And finally, again, it's Oral Health Awareness Month. It's Dental Hygiene Week next week. And so use that as your message, as your reason to make change, as a reason to do those screenings. If you're uncomfortable, reach out, take those courses, take the online courses, watch the YouTube videos. You know, it will get easier as you do it, but we've got such an awesome opportunity ahead of us.
Thanks, Carrie.
Thank you.
That was great. Thanks so much, everybody. Thanks, Joanne.
My
That's awesome.
pleasure.
Thank you very much, Joanne.
Absolutely.
All right. There was one request just that I leave this up for a moment, just in case anybody wants to see. There was a lot of stories that came in through the chat. So you can all head off of the meeting, but I'll just leave this running for another 2 minutes in case anyone wants to read through and honor the people who've kind of shared some of their stories through this chat group.
Oh, that's great. Thank you for doing that.
All right. Well, have a great day, everyone.
Take care.
Bye.
Bye.